Hello and welcome to the Auditing Antics podcast. So, this week we're going to be focusing on a topic that I'm noticing really has a lot of discussion already on LinkedIn, Michelle, and that's the mindset and the differences between our physicians and practitioners, us as auditors, coders. There's a lot of times that we have a disconnect there, and a lot of times where that causes our communication, our feedback from an audit, things like that to fall apart. So really focusing on trying to understand both sides today.
hmm Absolutely.
Now, to begin with, I like to really think about, okay, why is this happening? And to dissect that down and understand the why, we've got to look at that component of both of us, like two different sides,
Yes.
and why we're looking at something differently. And when I think about this topic, I think about a conversation I had with a physician before where he was very frustrated because the error rate was very high. He took it very personally as a clinician. And he asked me and he said, "Why are you qualified to even come here and review my documentation like this and say something like this to me?" And ever since that day, it's been very eye-opening because a lot of times there's not an understanding from our physicians as to why we are looking at this differently, why we have to have different viewpoints, why we're qualified to
hmm
have different viewpoints. And I just find that this is very important, especially if you're looking in your own career journey to move into an education type position, even with auditing. You've got to have a clear understanding of this.
Yeah, and I think something that's really important to keep in mind and differentiate between is how each party is viewing the documentation. So, from an auditing perspective, we're looking at medical necessity, we're looking at code selection, and we're looking at compliance through a non clinical lens. We should never be doing any type of clinical interpretation through documentation. And I think often that isn't communicated between the provider and the educator or the auditor. And I think, we got to try to have put ourselves in their shoes. So when we're coding and we're auditing and somebody QAs our work or we audit, I know how I feel when an error is pointed out. I feel like I take that very personally too. So when we're having these discussions, we really need to realize, "Hmm, dial it back a bit. They're people too. They take pride in their work just like we do. They have very important roles. They deserve a lot of respect. And we should try to approach that from a perspective of how we would want to be approached when trying to resolve an error or make a correction to their workflow or how they're doing something."
Yeah, and we have to remember too that when we think about the process of them going through their college education, their training, their specialty focus, all of those types of things, this is not a large part, if at all, in that training process. And I
Not at all.
remember, yeah, I remember working with residents, and
Mhm.
it's kind of funny because for years you try to educate and get them to understand the basics, and they just kind of sometimes will blow it off, not really see why it's important. But then they're getting ready to have their official full-time job after graduating residency, and they realize, like, oh crap, my bonus is based on this stuff that they've been
Yeah.
trying to tell me for 3 years. And then I distinctly remember a couple of times some residents coming into an office I was working in and wanting a crash course on E&M services when they started to interview and realize that that's what some of their pay structure was going to be built on.
Yeah, absolutely. I can remember um, July. That's always the big time of year when the new, fresh out of their residency or fellowship is coming in to, become an attending and just trying so hard to fight against everything else. Like there's so much when a new provider comes in as it is. They're learning the practice workflow in the cases of, coming fresh out of residency or fellowship or things. I'm sure there's a lot of things that they're having to work through. And a lot of times one barrier I noticed was administration or practice management, for example, not placing a big enough focus on allowing time for education in the area of compliance. That
Mhm.
was a big barrier that I saw when it came to that. Um, so there's definitely different things that fall into this, what creates this mindset gap that we see between
And
auditors and practitioners.
that's reminding me too, one other thing there, when we think about the process of, a residency program, sometimes faculty also have a disconnect in this area. So
Hmm.
if they're not fully understanding it, they can't pass that on to the residents that they're working with. So it really does heavily depend on the organization, the structure. Not every hospital is the same. Not every hospital offers the same sources to their staff. And we really, end up with this large disconnect in the industry.
Absolutely.
Now, when we're thinking about, again, the next step here about when the documentation is not equaling compliance, we have to also think about the fact that, okay, the intent may be there from the physician side, the practitioner side. So they know what they're doing, they know the care
Hmm.
they're providing, especially if it's a very highly specialized
Yes.
population they're working with or specialty they're working in, things like that. There's a lot that they are thinking through, but a lot of times we really are not getting it across to that their intent does not equal the compliance that we need to see in documentation.
Yeah, and from the auditor perspective, we aren't there to question the care that they provided to the patient. We're there to discuss what the documentation supported. So I think that can create some tension because providers sometimes go into these education sessions. Like a lot of times, I would say, Stephanie, would you agree that the provider has received their audit result prior to meeting with
Mhm.
you? They've read the comments and things, and they're coming in with all of this, you know, tension related to this person doesn't know what they're talking about. They're questioning the care that I provided when really we're just trying to show you that this was not demonstrated in the note. I I always try to start off any conversation that I have with a provider with that disclaimer that we're not I'm not here to question whether or not you did the work. I'm just here to show you how the documentation didn't reflect that through our conversation and talking about what actually happened with that patient. And it just makes me think of a really quick example of a conversation, a similar conversation that I had with a colleague last week. Related to monitoring for toxicity and how he met with a specific provider group and they were like all these labs were ordered. Clearly that's what I was doing when I was ordering these labs, was monitoring for toxicity, yet this was not conveyed in documentation. So this is one area where we cannot, your intent was to monitor for toxicity, but we cannot make that assumption just because those labs are present. Essentially, we aren't questioning that you're doing that, we're saying that wasn't demonstrated in your note.
Well, and a lot of times too, on the provider side, when I'm going into those feedback sessions or even group training sessions, things like that, I do make it a point to say quite often, from a coding perspective, this, that, and the other, making it very clear that I'm not coming in questioning the clinical side. And I know that you and I've talked about that whole phrase that people use at times, that if it's not documented, it wasn't done. And I absolutely despise that phrase because that's not true. we do know that a
Yes.
lot of times they don't have the proper understanding. Or how many times do we think that, or do we see that they think they're doing what we want them to do by putting in different phrases and
Oh, yeah.
saying, this was a highly complex patient because they think that that macro statement met that mark for our E&M guidelines. And it's just not the case, but it is what it
Yeah,
is.
and a lot of times what what I find is missing is they're just making a list in there. How many times, and I think this is actually a problem created by EMRs, and certain ones in particular, where they've just created this list, and they haven't told you the complexity of the patient. They haven't documented their thought process, so it wasn't clear through documentation what they actually did. I know I've had that on several lately where it was like just a bunch of orders and no thought process as to of why they were ordering this, what even was the status of the patient. I think that it's all kind of become a little convoluted. I think that we need to, like, I know the soap note really isn't relevant anymore with the new guidelines, even though the providers still document as if we are evaluating their documentation by 95, 97 guidelines. But we need to go back and stress that the history portion of the note is intended to be from the perspective of the patient. They're coming in, they're telling you what's going on, what's happened since they saw you last, and then the assessment and plan is where the provider is supposed to take all of the rest of that and put it into the complexity of the patient from the perspective of the provider. So when we're missing things like those key elements of knowing their thought process, that intent is just completely gone. I think where they provided all of this stuff when you and I go meet with them. They're like, oh yeah, we did this, this, and this. I reviewed these labs. It was showing this, and we're like, holy cow, what a different encounter than what was conveyed in your note.
Mhm.
And so I think it can very easily, they, because of their clinical mindset, I think too, that intent can be lost and it can be forgotten that these notes are used for non-clinical purposes.
Well, and I was just reviewing documentation earlier this morning where I could tell that the physician I'm auditing knows that we no longer score the history and exam,
Mhm.
because what they were doing is they're using a template and the HPI says none, the exam says none.
Mhm.
And then in the assessment portion of the note, it's this big paragraph that's supposed to include all of it, but they're not even using the word examination in that paragraph or showing
Yeah.
me that they definitively examined the patient, even though they're referring to things like shoulder pain. And,
Mhm.
that's really problematic. And that's a sign of a group that has not had proper education as we've gone through the different changes in
Yes.
E&M coding, because they've heard the one part that we no longer score history and exam, but they didn't hear the part that yes, you still have to perform them, and yes, the payers still expect that to be documented. Then I would
Yeah.
say, thirdly, like you were saying, that's going to give us a large amount of the insight into medical necessity, but there's just such a large problem when it comes to the little bits of information that everybody takes in that they think is going to make their process easier, or they think, is going to be more beneficial for the levels that they want to bill and things like that.
Yeah, it really blows my mind because sometimes I sit and look at a note and I'm like, they put all of their attention in the completely wrong place. And if they had just focused that energy by giving me an assessment and plan that was like 2 to 3 sentences instead of their templated thing that applies for everybody, and not trying to show all of that through a macro statement that really means nothing when it's not demonstrated within their note. Um, it would just be amazing. But a lot of it comes down to lack of education or needing to, having pressure put on their time and time constraints. It often isn't, I find it isn't the intention of the provider to be a bad documenter. It's just they've got to see 40 patients today.
Well, and
So
sometimes it's an outcome of their frustration, and that's the way they choose to quote unquote voice that.
that's
Because I've
true.
had situations where, I mean, I think it's pretty scary even from a legal or continuity of care situation that is separate from what we do for documenting and coding and billing and all of that. But I've worked with a lot of physicians who are incredibly frustrated because this is required. And,
Hmm.
how many times have we heard people say that they didn't go into med school to come out and document for a coder or to document for an auditor, but it's the reality. And not only is it the reality, it's getting worse and worse with the way that we're seeing the behavior of the payers change, the different
Yes.
investigative units, the government. There's a lot of things that can be used to identify issues. And yeah, they may not know that your documentation is incredibly deficient, but the second that your billing patterns show as an outlier and they ask for your notes, it's going to be glaringly obvious. And I don't think enough people take that seriously. And it's
Mm-mm.
always been a problem where, for example, I have a lot of horror stories that I've seen in my defense work, but nobody's going to believe that until it's at their door and they're having to answer to those things that we're trying to tell them on a regular basis.
Hmm. And when I'm auditing documentation, I'm looking at a couple of different things. Does the note support what was billed at bare minimum? And I'm commenting on that, but I'm also looking for how can we make it so this documentation doesn't need to be defended. And sometimes people are like, man, you're getting a little picky here, but some of that comes from my how do we make it so that it doesn't have to be defended, so that it doesn't have to be questioned from the get-go. And that's really where our intent, I know we use the word intent as coming from the provider's perspective and things like that, but from the auditing perspective, how do we protect you from having to defend yourself? And that really is, we're part of your team. We're not questioning your care, so if you can form these relationships and get off on that right foot and try to diffuse some of those tensions that sometimes exist, I think that that can have really good outcomes, in not having to defend their work at all.
Well, and one exercise that I find very helpful in audits when there's this big question or people are talking about the burden of documentation, or maybe different practitioners in a group have complained constantly that, the templates are too much, or, every note is taking so many minutes. One thing that I like to do is ask if there is like a lead physician that I can meet with and look from their point of view real time as they're documenting. And I've
Yeah.
done this more one on one with solo practitioners in behavioral health, for example. I'm not sure what it is about that specialty, but they struggle even more in this particular area, probably just due to the way that they go through the different specialty training. But I find that a lot in behavioral health struggle, and I'll finish an audit and they say, okay, great, let's make these tweaks so that, psychotherapy stands out with medication management or things like that. But they'll say to me, why is the print version of my note 12 pages long? So we're able to sit down, look through from a workflow perspective what they're actually doing, what is essentially blown in, because we know that there's certain parts of it that'll be carried forward as long as it's their note, and that's perfectly compliant, but we have to look at how that fits into the overall progress note. So
Hmm.
that particular activity has been really helpful because I don't know what a clinician needs in the documentation.
Yeah.
And I'll be asked at times to sit and look at a template or a completed note and to put comments, but I will always say with a disclaimer, I will go through and do this so that you can see from an auditor's eyes what it is we're looking for. But you have to also look at this from a clinician standpoint
Mhm.
because it's not one or the other, it's always both.
No, and that's kind of a pet peeve of mine is when you're sitting in a group and somebody is going through a provider's note and they're like, "We don't need this. We don't need this. Why is this here? Why do we?" And it's like, it's not just up to billing what goes in
Mhm.
there. That is up to the provider. And yes, sometimes we end up with a 12-page note, but having those exercises like you just discussed can be extremely beneficial. That's actually an excellent idea because at no point should we ever be saying to a provider, this doesn't need to be here. And that
Mhm.
includes, like you said, things like copied forward information or templated documentation, as long as it is being used in a compliant manner and not being, commingled and hard to tell what you actually did today. And that those exercises I think are a great idea to do.
Well, and I have a good example where the documentation style was an assessment and plan that had a list of all the diagnoses blown in, whether they were relevant or not, because the EMR gave them the option to click a button, they all came in. Then there were some orders. And then underneath that, there was a macro statement that said the patient was moderately complex due to this, that, and the other. And having the conversation when that did not result in a very good audit finding, the error
Mhm.
rate was pretty high. They kind of the physician or provider is sometimes confused, like, I thought I was doing what you needed, or this is in the guidelines, why wouldn't benefit me to put the exact words from the guidelines in? So those types of exercises definitely help. And that's another thing too. I've talked about this a lot. I usually bring this up every time I'm doing webinars or speaking at conferences or events, things like that. We as auditors and coders always need that viewpoint of our physician and provider. So
Mhm.
not only should you be asking questions like we talked about up to this point, but that is also the reason why I go into meetings wanting them to explain to me what was going on. Because
Mhm.
currently, and I always will say as well at the surface level, meaning we can only see what's in the document on the surface. We can't see what took place in that exam room or operating room,
Mhm.
whatever it may be. So we've got to have that discussion. Let the physician, the practitioner describe to you, okay, what is the typical way that you would treat a patient like this? Or what happened in this patient situation? Because somewhere we've got to find that middle ground. And
Absolutely.
if you have all of these findings, that physician can't come in and say, oh, well, these are the things that you're missing that would have made that a four.
Mhm. Yeah. And actually, um, that's another thing I try to do as I'm auditing is I'm as we have talked about previously, I've chosen to not do some of that education side of things with the providers and with the practices. But that doesn't mean that I can't, from the background as an auditor, point out areas where this had potential for a level four. It supports a level three, but I could see the potential here if you would have just done maybe XYZ or seen, expanded a little bit more on this area of the note, not being leading, you know what I mean?
Mhm.
Um, but we can point out those things and make our findings as auditors even more valuable to the educator because it's not always the auditor that educates that provider. Um, so I think it's important that we're not just including derogatory feedback to our providers. We should also point out what they've done really well in
Mhm.
in their documentation so that it kind of gives, we can kind of help set up that appointment, that education session with something positive, that they can say, look at, you did this really well. Now let's just focus on this other area and see how we can, get across a little bit better with a little bit more detail what your thought process was.
Mhm. And I also prefer, going into those sessions, the feedback sessions, I do prefer that physicians and practitioners have their results before. I know some people like to wait, but I find it's that much harder if they're blindsided. And,
Yeah.
I, if I'm sharing my screen, for example, I don't like to just show the score right away because that's not even what I'm focusing on. And, if sometimes when people see the score, they will be upset and they'll come to that meeting with that mindset. But it's that much worse if they feel caught off guard. They don't have an opportunity if they want to. Some are more thorough than others. Some want to go back in the notes, reread the notes. And, there have been times too where they come to that meeting and they're like, oh, I see what you're saying. I could have documented this better. I was thinking through another particular part of that and it just wasn't in the note, things like
Hmm.
that.
Yeah. Yeah. So, Stephanie, since we are auditors,
Yes.
let's kind of close this episode out by talking through what auditors are trained to look for. So I'm sure we have a mix of people in our audience of auditors as well as practitioners and physicians. So let's take a minute to just kind of highlight what we as auditors are actually looking for in the documentation.
Well, and so circling back to what I said in the beginning with that physician who questioned why I was qualified to be there, auditing him and discussing with him all of that. That entire conversation was around the basis that as an auditor, I am non clinical. Even if I
Hmm.
have clinical training, I'm not allowed to apply that. And it's because this type of audit, even for coders, it's done from the viewpoint of the guidelines and how that's supported in documentation. So we have to have a very clear line. And that's one thing that I find sometimes when, other auditors are talking and they're like, oh, well, this was just abdominal pain or this was just a UTI. It's like, okay, well, yes, I'm non clinical, but I've also learned a lot from the physicians and
Hmm.
practitioners I've worked with over the years. And I know what could happen, but we've got to stick to the here and now. We've got to stick to guidelines. I'm even finding, actually, Michelle, in the industry, especially when I'm involved in some of the payer work, they don't want the term medical necessity being used if it's a non-clinical auditor that's reviewing
Hmm.
documentation. Now, I don't fully agree with that because we're trained to look at medical
We
necessity from
are.
a coding perspective, but there's definitely this difference in opinion that I'm starting to see come out.
Yeah, that's really interesting. You do have a lot more experience than I do from the payer side. So that's kind of interesting that they're starting to look at evaluation of medical necessity to be more from a clinical standpoint than a coding and billing guidelines. And what's interesting to me is medical necessity can mean some different things. So
Right.
obviously we have E&M coding, but then we also have things like policies related to procedures and things where they have a whole list of criteria that says if this is not met, it's not medically necessary, where I don't really think you have to be clinical to know if the step therapy was performed and things like that. That was documented and is evident in documentation or it is not. So I find that very interesting that there's starting to kind of be this conversation around the use of the term medical necessity.
Well, and I think it really honestly stems from the fact that there is a misunderstanding because we could say medical necessity. We know exactly what that means with coding and policy and guidelines, but a physician's going to be looking at that very differently.
Mhm.
And to some extent, it could be something that's coming about because they want a more black and white case if there are issues with a certain physician or practitioner. But I've also seen it as well in other areas where, for example, if you are going to be doing an IRO review, so practices that are in a CIA agreement with the government have to have an IRO, which is basically this independent organization that's going to audit and hold them
Mhm.
accountable if there's issues found. It's a whole process. They have to report back to the government, all of that. But there are some different things that, will say if there is a medical necessity more from a clinical review, you have to have, for example, a nurse auditor or different types of licensing.
Mhm.
But to me, that's always existed because we've always had, the request for peer-to-peer reviews with physicians. We've had, clinical nurse auditors who are looking at notes for very different reasons. But I'm starting to hear that come over into the coding and billing side, which is interesting.
Mhm. Yeah, that is. So, from the perspective of what we're trained to do, we kind of got off on a little tangent
I
there
know, I know.
with medical necessity, but obviously from the surface we're trained to look at from an E&M perspective the medical decision making. We're trained to look at the time, is there time documented? I think that those are pretty well understood as far as what auditors are trained to do. We tend to dig deeper. Would you agree that an auditor will look kind of around, not just where coding is focusing on the record that is in front of them? Auditors should be looking around at what's happening to see,
Mhm.
is this consistent? um, we dig that little bit deeper. So, yes, on the surface, medical decision making may be met, but we may discover things like copy and paste of certain elements of data review and things like that. So, we tend to dig a little bit deeper, look all around the encounter, not just at what's directly in front of us. And I do think some may agree or disagree with looking around, because I know I've heard before some saying we're looking at what's happening right now, but often to understand if what's happening right now is supported, we have to go back. But also looking for those inconsistencies. How often do we review documentation and there's just like this real wacko element to it? Like, I'm looking at this note eh, just last week, and the patient's in the office, and then there is a physical exam that says no exam was performed because this was an audio only visit. It's like, well, we know where this came from. The last visit, or who knows how many visits that had been copied from. Do you know
Mhm.
what I mean? So we're looking for those inconsistencies. And then I hate to say the word medical necessity because of what we just talked
Well,
about, but does the
I still think we need
documentation,
to talk about it. It's good.
does does it support the reason for the visit? Essentially, does it line up? And I think where we can say providers and auditors kind of converge, where we come together is in that assessment and plan. Is
Mhm.
where they can kind of come together. And as long as the provider is providing us with good clear documentation, in the perfect world we would want to see the status of the condition. What's their thought process to the treatment plan that they're implementing? Did they order tests? Did they review tests? How did they use the review of that test? And I know it sounds like this could be us looking for this long, lackadaisical note from the provider, but really, you could sum this up in 1 to 2 sentences.
Mhm.
That two really well thought out, information packed sentences, and you can move on to the next condition and not just do this list and then this template
Mhm.
about vague template about this list you blew in.
Yeah. Well, and to round out this episode too, think about, when you have issues that you're finding, it's not your job to only go forward with the issues at hand. You also need to be thinking about the solution. You need to
Mhm.
be a part of the solution. So what Michelle is describing there is a lot of what I will talk about in my sessions as well, where okay, we're going to break down what is missing, but then let's talk about, from the physician's standpoint, what were you thinking at the time? What concerns were there? Were there complications involved you had to think through? With medications, did you have
Mhm.
to consider other medications and those interactions and, things that I know could exist, but I'm not qualified to say that.
Yeah.
And I'm very firm when I look at this from the standpoint that if we have moderate and high complexity patients, we have got to see free texted documentation.
Absolutely.
If we don't have free texted documentation, it leaves the auditor in the category of having to assume something which they shouldn't be doing, and that leads to compliance issues as well. So higher levels need free texting.
And the funny thing is it's the lower levels where we generally see the free texting.
Mhm.
Um, I don't know if you notice that pattern as well, but that documentation style of just giving a list of conditions and not providing clarity of what you did for each of those things, or maybe one of those items impacted how you treated, a specific condition. I think of like diabetes, for example.
Mhm.
That can be present and in a problem list, because that's all that is when you put that list in. That can be present in a problem list. And I think of orthopedics, or things like that, where they're giving a steroid injection or prescribing a steroid. But you see, they have diabetes. It's one of those things where you and I know these two things do not go well together. You have to do monitoring, but then they mention nothing about it. And then you meet with the provider and they say, well, I have diabetes listed here. And
Yeah.
it's like, yes, I understand that. However, you didn't tell me why you have it listed there for me to know the intent behind why you were thinking this was increased complexity. So,
Mhm.
there just has to be a little bit of that gap closed. And I think we can do that by having, you know, better conversations and trying to resolve some of the tensions that tend to exist between compliance and physicians and practitioners.
Yeah. Yeah, we come to the meeting, they may be all over the place as far as thinking of what it is that's needed, but then guide, talk together, figure it out, and, tie up the documentation so they're not spending extra time in a place that's not really
Mhm.
helping coding if they don't feel that that's as relevant from a clinical perspective either.
Yeah. And you have to consider possibly what they've just been through before the meeting. Like, I remember being scheduled to meet with an OB. She had just been on a night shift, so she worked all through the night. She had just come from an emergency C-section, and like, her body was like, I'm sure, at 110, you know, from everything she just had to go through, and then is expected to sit here and care an ounce about what I have to say. You know what I
Yeah.
mean? Like, I can reckon I actually said to her, I said, "Let's just reschedule this because I
Mhm.
think that you would benefit from just going home." You
Yes.
know? Like, some things can wait until tomorrow. And,
Right, right.
we have to recognize that as well.
Yes, I agree. All right. Well, we'll go ahead and end it out here for today. I hope you have some good takeaways as far as viewpoints, ways that you can look at collaborating. Remember,
Mhm,
we're supposed to be a team. We're not supposed to be coming in with one side against another, things like
mhm,
that. So just think about that middle ground as the goal for everybody and try to work towards that. And, I think you'll find if you've been struggling up to this point that you can accomplish a lot more.
mhm.
All right. As always, please find us on your go to platform for podcasts. Rate, like, subscribe, share, comment, all kinds of things. Again, this has been a really great start to 2026, and I'm loving all the engagement. We have a lot of people that are reaching out on LinkedIn, things like that. So thank you for that. Please continue to share with your friends, your coworkers, all of that. Next week, we'll see you back. We're going to be talking about some of the specifics related to what is built into payer algorithms and how billing data can basically, send out some red flags about activity that could be happening in a practice. So hope to see you back next week and have a good rest of your week.